So welcome everybody to our third Lunch and Learn session. We're very excited to be offering the seminar series on a monthly basis. And today we're very lucky, well actually I should introduce myself. My name is Joanne Kotsopoulos. I'm a scientist at Women's College Hospital. And along with Dr. Kelly Metcalf, we decided to offer this virtual seminar series to high-risk women. And so today I'm happy and very excited to introduce Dr. Ellen Warner, who is our speaker for today. And she is a medical oncologist at the Sunnybrook Odette Cancer Center and a professor at the University of Toronto in the Faculty of Medicine. Her large clinical practice and research are devoted exclusively to breast cancer. She has led a multidisciplinary team of investigators who found that breast MRI imaging added to mammography was better than mammography alone for screening women with the BRCA1 or 2 mutation. And this research has resulted in the creation of the high-risk Ontario breast screening program. Dr. Warner is also founder and director of PINK, breast cancer program for young women at Sunnybrook. PINK, spelled P-Y-N-K, addresses the special clinical and research needs of women diagnosed with breast cancer at age 40 or younger. So Dr. Warner, thank you for taking time in your busy schedule, and we're very excited to hear your presentation. And just before you get started, please enter your questions that you might have in the chat box, and then at the end, Dr. Metcalf and I will help navigate any common questions that come up.
Thank you, Joanne. One of the most difficult decisions for women with BRCA mutations is choosing between having both breasts removed surgically, what we call risk-reducing mastectomy, or instead having regular breast screening in the hope that if breast cancer occurs, it'll be detected at a stage when it's still curable. Risk-reducing mastectomy is extremely effective. It prevents more than 95% of breast cancers, and today there are multiple reconstruction options that give excellent cosmetic results. So why do we need screening at all? Well, for some women, screening is a temporizing measure. They want to have risk-reducing mastectomy, but not yet. First, they'd like to have a stable relationship with an intimate partner, or perhaps they want to finish all their pregnancies and breastfeeding. Some of them simply want to wait until they reach an age where their risk is unacceptably high. For other women, they're willing to wait and see if they ever get breast cancer. They're perfectly happy to be screened, but if they do develop breast cancer, even if they would be candidates for lumpectomy and radiation alone, at that point, they want both breasts removed. But there are other women for whom mastectomy is unacceptable under any circumstances. In fact, I have some women in my practice who've had a breast cancer treated with lumpectomy and radiation, and 10 or more years later, they develop a new breast cancer. And for that, they want repeat lumpectomy and re-irradiation rather than have mastectomy. So why are women so averse to mastectomy? Some consider it to be mutilating surgery. Why remove healthy breasts? Or for many women, the breasts are actually a source of sexual satisfaction, and they don't want to lose them. For some women, losing the breast is fine, but it's a reconstruction that's unacceptable. They don't want to have foreign implants. They don't want to have a scar on another healthy part of their body. Other women say, this makes no sense. If I had breast cancer, you would do a small lumpectomy, but to prevent breast cancer, I have this huge surgery. There are women who say, well, maybe I'll never get breast cancer. And if I take out my ovaries before menopause or take tamoxifen, that risk will be even lower. Some women say, okay, most breast cancers are curable. I can live with that risk. And besides, if I have regular screening, then that chance of cure will be even better because cancers will be found at a much earlier stage. So what's screening? Screening is checking for a disease when there are no symptoms of that disease with one or more goals in mind, either increasing the chance of cure, and that's certainly why we would screen for cancer, decreasing the risk of complications for some other diseases, such as diabetes, which are incurable. And for many diseases where we screen, the goal is really to allow less complicated treatments. So in the case of breast cancer, we're definitely screening for it to increase the chance of cure. And the rationale for that is Overall, in general, the smaller a cancer is when it's found, which is what you do with screening, the more likely that woman is to be cured. Now, I say in general because there are obviously some women with very tiny cancers who are going to die of their disease, and there are lots of women with very large tumors who are cured. But this is overall when we're talking about a population of women. And certainly, if that cancer is found earlier, the treatment is going to be less extensive, less surgery, perhaps chemotherapy won't be necessary, perhaps radiation can be avoided. Screening does not lower breast cancer risk. Now that might sound like a ridiculous no-brainer. Of course it doesn't. The goal is to find cancer, not to prevent it. But believe it or not, I've had several women tell me, what, I have cancer? How could that be? I've been getting regular screening. And these women aren't stupid. What's very confusing is that many women are also being screened for other cancers, like cancer of the cervix, cancer of the colon. And in those cases, screening can often detect lesions that haven't yet become cancer, but would become cancer if left in place, but are being removed. So in fact, for those diseases, screening actually lowers the risk of cancer. In the case of breast cancer, we don't have any precancerous lesions to remove. So screening does not lower risk. So in order to understand how screening works, you need to understand a little bit about breast anatomy. Don't worry, this is going to be really simple. So on the left, we have a picture of a breast. You're looking at it from the front. And in that breast is tissue, which is bathed in body fluids. Those fluids drain through little lymphatics. Here's my arrow, into lymph nodes, which are in the underarm area, or what we call the axilla. And this fluid goes from node to node, eventually to the neck, eventually back into the body's circulation. Now, if there's a cancer inside that breast, that cancer can shed cells, which often follow those little lymphatics into the nodes, etc. And from there, those cancer cells can spread to other parts of the body. Those cells can also enter little tiny blood vessels and spread to the bloodstream. The bigger a cancer is, the more likely it is to spread to other parts of the body. And that's the whole rationale of screening. So let's pretend that we're virtually, of course, slicing this breast from top to bottom through the nipple, getting rid of this left half and looking at it from the side. So then you have the picture on the right here. And just to orientate you again, here's the nipple on the right, the chest wall on the left. And in between is the breast tissue, which is a mixture of fatty tissue, this yellow stuff, and glands that produce milk. This milk goes through little tubes called ducts and empties out in the nipple. And that's, of course, how babies breastfeed. There's that same picture, but now on the left. And here, in this little duct, is where most breast cancers start. Here is the tube, the duct. And in a cross section, you can see that the ducts are generally lined by a single layer of normal-looking cells. If one of these cells or more become malignant, they start to grow out of control, they start to multiply, and they start to pile up within this duct. And that is the earliest form of breast cancer, called intraductal breast cancer, or non-invasive breast cancer, because the cells aren't spreading outside the tube. Or if you want to be really fancy and speak Latin, it's called ductal carcinoma in situ, or DCIS for short. So all those names say exactly the same thing. The important thing, though, is that when these cells are still confined within the duct, there are no little lymphatic spaces here, there are no little blood vessels here. These cells cannot get out into other parts of the body. So if you find breast cancer at this stage, it is 100% curable. And that is where we would really ideally love to screen everyone and find all the cancers at this stage. So here on the right, again, is your intraductal cancer. But here below it is what we call an invasive cancer. These cells have multiplied and become more aggressive and been able to blast through this barrier called the basement membrane and get out into the surrounding breast tissue, where they can now spread to other parts of the body, perhaps. So how can we screen for breast cancer? Well, here are some of the ways we used to think we could screen for breast cancer. One was called breast self-examination. And most of you are probably too young to remember this, but for years and years, women were blasted with the message, you must do monthly meticulous breast self-examination in order to find breast cancer early and save your life. This was so ubiquitous. It was a message that women got as often as we now get don't drink and drive, wear seatbelts, and so forth. However, at one point, somebody looked at the evidence, and it turned out that monthly breast self-examination, at least for average risk women, does not prevent breast cancer death. Ditto for its cousin, clinical breast exam. Here, the breast exam is done maybe every 6 months or a year by a healthcare professional. Again, no effect on breast cancer death. What does work is mammography. So here's a schema of how mammography works. You've got basically an X-ray machine. X-rays penetrate through the breast and create an image. It used to be on a film. Today, it's a digital receiver, which creates digital images of the breast. The catch is that in order to minimize the amount of X-rays being absorbed by the breast, and in order to get the best possible image, you want to flatten that breast out, kind of like a pizza, squished between these two plates. The better the squish, the better the image. And this mammography technologist obviously did an excellent job. So what the image looks like depends very much on the composition of the tissue within the breasts. So on the what happens is when X-rays go through air, they blacken the image. You just get a plain black image because nothing's absorbing the energy of those X-rays. When X-rays go through fat, the image is also very dark because fat doesn't absorb a whole lot of the energy of the X-rays. When X-rays go through blood vessels or fibrous tissue or glandular tissue, then you get a white image. So what you're seeing here is a breast that's very fatty. So the image is very dark. And if you had a tumor here, it would be quite easy to see it, as tumors tend to be composed of a lot of fibrous tissue, which shows up as a little white mass somewhere in the breast. And I'll show you that in a minute. So as we go along here, we get breasts with increasing amounts of glandular tissue, and usually fibrous tissue goes with that. And you get oops. Sorry about this. Okay, how do we get this back? How do we get this back? There we go. Okay, so we have increasing amounts of glandular and fibrous tissue, and you can see an increasingly white fuzzy image where a tumor would be harder and harder to see. In general, the younger a woman is, the more dense, that's what we call this fibrous and glandular tissue on the image. The more dense her breast tissue is, the more dense the mammogram. So here we have two images. On the right is an image of a woman with a very, very dense breast. She's got a cancer here, but it's impossible to see. It's hidden by all this dense tissue. On the left is a woman with a fatty breast. You can just see little streaks of some glandular tissue and some blood vessels, and it's relatively easy for the radiologist to see this tiny tumor here. So how does mammography detect cancers? Well, you might see a mass, as you just saw in the last image. You might see architectural distortion. That's something that only radiologists can see. So I can't even show you a picture of that. But with their trained eyes, they can see changes in the tissue, and I guess this distribution of the blood vessels and so forth that makes it look like something is pushing or pulling. And finally, abnormal calcifications. Calcifications come out very white on an image, and you can see the calcium here. Some calcifications are benign and some are malignant. And again, that's why we need radiologists. Sometimes they can't tell and we have to do biopsies. So when we're talking about the general population of women, in other words, average risk women, from age of 50 onwards, if those women have mammography every 2 to 3 years, their risk of dying of breast cancer is reduced by 25%. So what's so special about that number 50? Well, if you actually look at the risk of a woman developing breast cancer by a certain age, this is the general population. By age 50, only 2% of women have developed breast cancer. But then over the next 10 years, another 2% will get breast cancer. So it makes sense to start screening at age 50. After age 60, it's an even greater risk. But what about mutation carriers? What you see here is by the age of 30, 1% or 2% of these women have already developed breast cancer. So it makes sense to start screening them starting at the age of 30. We also want to screen them not every 2 to 3 years, but every year. And that's because, first of all, the younger a woman is in general, the faster her tumor is growing. And on top of that, for women of a particular age, BRCA mutation related cancers seem to grow a little faster than non-BRCA cancers. That's of course in general, there are exceptions. So certainly screening every year seems important. So what do we want from when we're screening BRCA mutation carriers? Ideally, we want to be able to detect every single cancer before it's big enough to be felt by the woman or by her doctor. We'd like to catch all those cancers when they're still at the non-invasive stage. And if we have to find them at an invasive stage, and that's from a practical point of view, it's impossible to find every cancer still at DCIS because some of them progress very quickly from intraductal to invasive. Then at least we don't want those invasive cancers to be more than 1 centimeter in size. And we don't want them to spread to the lymph nodes, because if we catch them at this point, the cure rate is well over 90%. Well, what happens when we screen women with BRCA mutations with mammography? It's not so good. We miss half the cancers. The rest pop up between rounds of screening as what we call interval cancers. We hardly ever find DCIS. Half the cancers are more than 1 centimeter in size, and 30% are node positive. So why doesn't mammography work well for BRCA mutation carriers when it works so well for women 50 and over in the general population? Well, first reason is, in general, younger women have denser breasts. So just by starting to screen women at age 30, you're overall going to be dealing with much denser breasts. Also, most breasts, even ones that are mostly made out of fat, have some densities where tumors can hide. If you're an older woman with a slower growing tumor, that cancer will wait for you. It can wait for 2 or 3 years. And the next time you have screening, it'll be a little bit bigger. It'll be peeking out from behind the dense tissue, and the radiologist will be able to find it. But if you have a BRCA mutation and a very rapidly growing tumor, that cancer is not going to wait for the next round of screening, even if it's only a year later, and it's going to present as an interval cancer. Also, BRCA1 related tumors have some special features that we don't really see so much either with BRCA2 or with tumors in the general population. Calcifications are very uncommon, and they seem to have a lot less fibrous tissue, so they don't show up as well on mammography. So in the mid-1990s, we had a big dilemma. BRCA1 and 2 had been discovered. Testing for mutations was now available to women. But what could we offer them? Mastectomy? Not a great option at the time. We didn't even know if it worked because we knew we couldn't remove every single breast cancer cell. So some of these women would get breast cancer and we had no idea how many. Also, the reconstruction options at that time were really limited. As you saw, mammography was not a good way of screening these women. So what was the point of testing them if we had nothing to offer them? So we came up with an idea. There was this new imaging technique called magnetic resonance imaging, or MRI. And this is what the machine looks like. It had not been used yet in screening, but was looking very impressive in the breast diagnostic setting, helping radiologists decide whether a particular lump was benign or malignant. It had a lot of theoretical advantages over mammography that might make it a really good screening technique. It wasn't as affected by breast density. And that's partly because rapidly growing breast tumors produce their own little blood vessels in order to get more nourishment and be able to grow faster. These blood vessels are a little bit abnormal and leaky, and MRI uses a contrast agent that's injected intravenously called gadolinium DTPA that goes into those little blood vessels, leaks out, and allows us to see the tumors very clearly. Also, instead of mammography, which gives you one image of a breast squished together where the X-rays have to go through the whole volume of the breast tissue, here we get virtual slices that are very thin of breast tissue. So again, it's easier to identify small tumors. Also, if we're going to do an extra imaging technique, we don't want to give women more radiation, and this did not. And finally, women were thrilled to hear that there would be no breast compression, just something to immobilize the breast a little bit in the machine. But MRI had a lot of potential disadvantages. At the time, it was incredibly expensive. It's still much more expensive than mammography, but it has come down in price. Calcifications don't show up. It has a lot more false positives. False positives mean the radiologist sees something, it might be abnormal. The woman has to be called back for more imaging, possibly even a biopsy, obviously generating a huge amount of anxiety, particularly in a woman who knows she's at high risk. Biopsies are technically more difficult under MRI than they are with other modalities. So that's particularly a problem when you have a lot of false positives. We also have a lot of logistic nuisance problems with MRI. The timing, to get the best image, you want to do it in the second week of the woman's menstrual cycle. Because magnets are attracted to metal, if the woman has certain types of metal in her, such as a shrapnel injury in the eye, if she has certain kinds of surgeries that leave metal, she might not be able to get MRI. MRI is dangerous in women with kidney disease, which you'll see, and some women are large and simply don't fit into the magnet. Also, some women get claustrophobic lying on their tummies for half an hour in a closed tube. And though we can usually treat that with some Ativan, even that's not enough for some women. And a lot of women don't like getting intravenous, particularly if they have poor veins. So this really needed to be tested in a research setting. And in 1997, we launched our MRI screening study. It was for women with BRCA 1 and 2 mutations, age 30 to 65. We offered them annual mammography and MRI, and all the imaging was done at Sunnybrook. So I'd like to tell you about a case. This is one of our first participants in the study. She was a 45-year-old Jewish woman whose father's sister had had ovarian cancer, and she read about BRCA 1 and 2 and realized she might be a carrier. But she didn't want to be tested. As she told us, she said, what's the point? I'm already getting mammography every year. I don't want my ovaries out, and I don't want my breasts taken off. What she did want to do was store her blood in case something happened to her and her children might want to know her test results in the future. So we took her blood and we sent it to the lab. But there was a miscommunication. The lab tested her blood and found a mutation and informed us. What do we do? It's an ethical dilemma. Do we tell her? She doesn't want to know, or do we not tell her? So anyways, we decided to tell her. And we put it to her sort of as a good news, bad news thing. The bad news, you have a BRCA1 mutation. The good news, you are eligible for our study. And she was thrilled about the study, and she enrolled. And this was her first round of screening. On the right is that dense breast I showed you before. It looked exactly like all her other images from all her other mammograms, and the radiologist called it normal. But here was her first MRI. Now, what's important is this was done in 1997 or 1998. The quality of this MRI is horrible. It's grainy, it's blurry. MRIs look way better today. This looks kind of like the old Polaroid photographs we used to take as kids. But even without the radiologist arrow, you can see this tumor from the back of the room. And we took it out and we radiated her breast and we gave her chemo, and she went into menopause and let us take out her ovaries. And she's now almost 70 years old, and she still gets MRI and mammography every year. She still has both her breasts, and she's perfectly healthy. And we have lots and lots of women like that on our study. So by 2008, we had already enrolled a lot of women in the study, and there were 10 other similar studies around the world, and they all showed the same results, that MRI was way better than mammography at finding breast cancers and mutation carriers. Mammography found about a third of the cancers. MRI alone found more than twice as many, and the two together would find 84%. Pretty good, way better than what we saw before. But what about ultrasound? I mean, ultrasound can find cancers missed by mammography if you use it for screening. It's the easiest image for biopsies. There's no breast compression, no radiation. It's relatively inexpensive. Why not screen with ultrasound? Well, that's a great question. So we did. So in fact, when we started our study, women were screened not only with mammography and MRI, but also with ultrasound. But what we found was that it almost never finds cancers missed by MRI. And worse than that, it generates a lot of false positives. So the role of ultrasound screening is really only for women who can't undergo MRI. And in that case, it certainly helps mammography. Also, ultrasound seems to be particularly good in women with dense breasts, but not nearly as good as MRI. Its main use now in BRCA screening is for women who are getting MRI, have a lesion found on MRI, and need a biopsy. And if you can find it on ultrasound, it's technically much easier to do that biopsy under ultrasound and not under MRI. So in the last part of my talk, what I'd like to answer are three very important questions about screening. And the first question is, does screening MRI work as well outside of a research setting? And the thing is, a research setting is like, it's a very controlled setting. You have trained radiologists, trained physicists with lots and lots of experience and some extra time on their hands because they've got academic time to look at the images carefully. They're not under so much pressure. What happens in the real world? Well, the best way to answer this question is our Ontario Breast Cancer Screening Program, High Risk Program. This was the first population-based screening program for high-risk women for women high risk for breast cancer in the whole world, where the idea was to offer high-risk MRI-based screening to every single eligible woman, regardless of where she lived or who her physician was. The program launched in July 2011. We offered MRI and mammography every year to all the women, ultrasound only if MRI was not possible for medical or for psychological reasons. High risk was defined as more than a 25% lifetime risk of breast cancer. And this included women with BRCA mutations. Initially, that was all we had, but over time, we started testing women with other high-risk genes, and they were included as well. A woman could also be included if she didn't want to be tested herself, but had a mother, sister, or daughter with a known mutation, or a father, because of course, too, father, brother, or son. Women with very strong family histories were also included if it was more than 25% lifetime risk or previous chest radiation for lymphoma at a young age. It's offered to women between the ages of 30 and 69. Once women hit the age of 70, they continue in the program, but they get mammography alone without MRI. So why do we stop MRI? Two reasons. One is that there is no data from research. In all the research studies, there were no women over 70 included. Also, we think that mammography should work much better in women 70 plus. They tend to have less dense breasts and slower growing tumors. Women with previous breast cancer are also eligible as long as they still have at least one breast, and it's open in 26 centers across Ontario. Last year, we decided to review the results for the first 5 years of the study. And here's what we found. So this is just for the mutation carriers, which were about 20% of the 9,000 women who were enrolled in the program at the time. And you can see that more than 90% of these women have BRCA1 or 2 mutations. Small number actually have both. And then under 10% of the women have other mutations. This number today is probably a lot higher because we're now doing a lot more panel testing. So the cancer detection rate. So focusing on the highlighted row in yellow, there were 115 cancers found in the mutation carriers overall. MRI found almost 90% on its own. Mammography found less than half of them. And either mammography or MRI or both found 95% of the cancers, with only 5% of the cancers popping up as interval cancers. If you separate that out by age, though, you see some interesting patterns. For the women in their 30s, MRI found every single cancer. Mammography didn't detect any additional cancers, and there were no interval cancers, although it's probably just a statistical fluke because of a small number of women. In their 40s, mammography found one cancer missed by MRI, but for women in their 50s, 10% of the cancers were missed by MRI, but found by mammography. False positives, always a worry, especially in very high-risk women. So the problem on the first round of screening is the radiologist has no prior films for comparison. So anything that shows up that's the least bit suspicious has to be investigated with repeat imaging and possibly a biopsy. So in the first round of screening, there's a very high recall rate. 28% of the women are called back for further imaging, 8% for biopsy. Fortunately, once they've had their first round of screening, there are now previous films for comparison, and the only things that have to be investigated are changes. So this number drops down to 15%, this to 4%. In other words, the number of false positives is slashed in half, and that becomes a reasonable number for high-risk women. But finding cancers isn't enough. Are we finding them early enough? And we didn't break down the tumor features according to the mutation carriers. This is for all 9,000 women in the program, but you can see almost a quarter of the tumors are found at the ideal DCIS stage, and only 11% are over 2 centimeters. Only 11% are node positive also. So almost 90% of these women are being diagnosed at the ideal of DCIS or stage 1, with cure rates well over 90% for the stage 1 patients. Very exciting and very encouraging. So we've answered, does screening MRI work as well outside a research setting? It certainly does, probably better. That's because it's a little bit later. Is prolonged MRI screening safe is an important question. If a woman enters this program at age 30, she's going to get at least 40 MRI scans over the course of her lifetime, and probably a lot more if she's called back because of false positives or because she's developed cancer. So what are the risks? Well, it doesn't look like MRI per se has any risks. The magnetism doesn't seem to cause cancer the way too much X-ray radiation can. But the gadolinium contrast agent does have some risks. And one is a disease called nephrogenic systemic fibrosis. I've actually never seen a case, but apparently it's a horrendous condition of fibrosis of skin, muscle, tendons, and inner organs. But it's only seen in patients with severe kidney disease. And that's why today, if a woman is going to get an MRI with contrast agent, she always has to be screened for kidney disease if she's a certain age or on certain high-risk medications. And that's why women will have their blood drawn and tested for serum creatinine, which is a measure of kidney function. More recently, we found that the gadolinium contrast agent can stay in the brain. It's less common with certain agents than with others. It doesn't appear to have any harmful effects on the brain that anybody has ever been able to detect, but it's just something we have to know about. So is prolonged MRI screening safe? It appears to be. Finally, what is the risk of dying of breast cancer if you're on a lifetime screening program? And for that, we decided to look at the long-term results of our own screening study. And these were women enrolled between 1997 and 2011. After that, most of these women rolled over into the Ontario high-risk screening program. So we had 489 BRCA mutation carriers who had no previous history of breast or ovarian cancer prior to enrolling. Their average age at their first MRI was 43, and their average time of follow-up was 13 years. 19% of these patients had bilateral mastectomy somewhere along the way, and that's corrected for in the statistical analysis. And 19% of these women developed breast cancer at some point between enrolling in the study and the time we did our analysis a couple of years ago. 72 of these 91 cancers were invasive. And this slide is just to show you that breast screening does not prevent breast cancer. So these women are all cancer-free at the start, and statistically within 15 years, 25% of them will have developed breast cancer. So just over 2% per year develop breast cancer. We had only 4 deaths. And the good news is in all 4 of these deaths, we have kind of an explanation that would tell us, well, maybe if X hadn't happened, this woman wouldn't have died. The first woman declined adjuvant hormonal therapy. The second patient stopped screening for 3 years to have a baby and then breastfeed for 2 years, and then presented with a very large cancer with large lymph nodes. But if at that time we weren't doing any imaging on women who were breastfeeding, today we would have done it. And perhaps that would have saved her life. The third woman was diagnosed in her first round of screening with a large tumor that had spread to lymph nodes. And even if she had undergone risk-reducing mastectomy at that point, she still would have died of a breast cancer. And the last woman developed a second malignancy at some point along the way, and it's not clear which one actually killed her. On the other hand, there are 2 additional women who we know have stable metastatic disease right now, but may well die of their breast cancer at some point in time. But this is still a very low death rate, calculated to be 94% survival at 10 years, 90% survival at 20 years, for the 72 women with invasive breast cancer. And what's interesting here as well is in my practice, I very often see women whose breast cancers come back after 15, 20, 25, even 30 years. We didn't see any of those cases. And I think that something is unique about BRCA-related cancers, that if they're destined to recur outside the breast, the kind of recurrence that can kill people, that doesn't happen after the first 7 or 8 years. So I think if a woman's gone 10 years disease-free, yes, she can get a new breast cancer in that breast or in the opposite breast, but that original breast cancer is very, very unlikely to cause death. So for the 489 women in the study, the 20-year breast cancer-free survival was estimated to be 98%. That's very, very good. Just to put it in another perspective, we saw 4 breast cancer deaths. We would have expected among women in the general population of the same age over the same time period to have 2 women die of breast cancer. And just to show you, there were other women who died. Most of them did not die of breast cancer. The major cause of death was cancer, but it was actually ovarian or ovarian-like cancer. More women died of that than of breast cancer on the study, which again stresses the real importance of women removing their ovaries and their tubes and having the pathology assessed by an expert pathologist to look for very early signs of ovarian cancer. But probably a more relevant question for women making the decision about risk-reducing mastectomy versus screening is, what is the difference in the chance of death between these 2 options? And the best way to look at that is the Hebon study. I don't know exactly how to pronounce it, but this is the Hereditary Breast and Ovarian Cancer Registry in the Netherlands. And this registry started in 1995. And at the time of the study, almost 3,000 BRCA mutation carriers were available to be analyzed. They were from 8 academic centers in the Netherlands. Just over 60% had opted to have breast screening, just under 40% risk-reducing mastectomy. Now, the Netherlands is a really good place to study this kind of question because they have one of the highest uptakes of risk-reducing mastectomy in the world. Kelly can probably tell you more about this. She's the world expert on this. And the average follow-up of these women was 10 years. So just looking, I've split them up into BRCA1 and 2 because they have slightly different outcomes. So focusing on the BRCA1 carriers. So if we look at the women who underwent screening, about 25% of them developed breast cancer over the time period, which is what you would expect. And only about 7% of those women died of their breast cancer. Overall, for the whole group, 2% died of breast cancer. For the risk-reducing mastectomy group, just over 1% developed breast cancer, with only 1 death, 0.1% of the population. On the BRCA2 side, of the women who had screening, 5% of these women, 19% sort of developed breast cancer, and only 5% died of their breast cancer. That's 1% of the whole population. On the risk-reducing mastectomy side, no breast cancers and no deaths. But again, it's only a 10-year follow-up, or at least an average 10-year follow-up. So is screening safe? Depends on one's perspective. Keep in mind that 2 to 3% of women in the general population are going to die of breast cancer. For mutation carriers, at least based on these studies, which started 25, 30 years ago, we would estimate that the death rate for those patients would be about twice as high, so 4 to 6%. Although the deaths would be at a somewhat younger age than the women in the general population, because breast cancers and BRCA mutation carriers occur at a younger age. However, screening keeps getting better and better. We're finding these cancers at a earlier and earlier stage. And most important, breast cancer treatments keep improving. In the last 30 years, every single year, there has been a better and better chance of a woman being diagnosed with breast cancer that year being able to say that she'll be cured. So these numbers are going to get better and better all the time. And we all take risks. We drive on the highway. We ski. I ride my bike to work 9 months a year. But obviously, for every single woman, it's a personal choice. So in my last slide, I just want to briefly review some of the avenues of research that are happening in breast screening for low risk and high risk women. One is improving technology. And one of the most exciting things that's happening is something called breast tomosynthesis, which is basically 3D mammography. So one of the advantages of MRI was that you got those thin slices of tissue, virtual images, which we didn't have with mammography. And the reason we didn't have that until now with mammography is because the amount of radiation that you would have to give that breast would just be excessively high. Well, our brilliant physicists have finally found out a way to minimize that radiation and break it down basically to the amount of radiation from a regular mammogram. So we're now testing tomosynthesis, this 3D mammography in clinical trials. And there are also contrast agents that can be given. This is never going to replace MRI. It's not going to be quite as good. However, for women who can't get MRI, this might turn out to be an excellent choice, particularly for those women 70 plus who aren't getting it right now, or for countries where MRI is just not affordable. Also, 30 minutes in an MRI machine is really torture for a lot of women, particularly if they're claustrophobic. There are now a lot of research protocols. They're able to get MRI down to about 10 minutes without losing any of the ability to detect breast cancer or increasing the false positive rate. Very exciting. And since we're worried about that contrast agent, yeah, it looks safe, but it's sitting there in the brain. Wouldn't it be nice to not have that MRI contrast agent? Well, that's being developed as well. And some of these new techniques not only eliminate the contrast agent, but seem to be able to do MRI with fewer false positives. Another line of research is refining the recommendations. So right now we're doing mammography with MRI starting at age 30 for high-risk women. Maybe we don't need it till age 40. As you saw in our results, we weren't getting any additional cancers by doing mammography for women in their 30s. And a lot of researchers have found the same thing. So perhaps our recommendations will change in the near future. Also, perhaps MRI doesn't have to be done every year throughout that whole age span. Maybe much younger women need it a little more frequently, and maybe older women don't need it as often. And we're not doing MRI in women age 70, but we're going to have to look at this population and see maybe there's a subset of that population that should still be getting MRI, such as the women who still have dense breasts. So since you can't do a breast cancer talk without a pink slide, this is my pink slide. And I want to thank you all for listening and for your attention. And I look forward to answering any questions.
Thank you so much, Dr. Warner. That was a very interesting talk, especially with the history, because I suspect some women who are on today's talk were probably some of those early participants in your MRI study. So I always think it's nice to bring the research back to the people who participated and volunteered their time to see what impact their participation has had on research, and then how that has been implemented into clinical practice to help thousands of women around the world. So thank you. So I'll just remind everybody that's on today's talk that if you do have a question, please type it into the Q&A little icon down there. And Dr. Katsopoulos and I will go back and forth with some of your questions. Some may be similar to other questions, so we'll try and group them together. So Dr. Warner, one of the questions that I've read from one of our participants related to breast screening after bilateral prophylactic mastectomy. Are there any current recommendations on how these women should be monitored after they elect to have preventive mastectomy?
Okay, that is a great question. And I was actually going to include it in the talk, and I thought, no, I'm sure someone will ask it. So we'll leave it for them. As you saw, after risk-reducing mastectomy, the risk of breast cancer is extremely low. So it really doesn't make any sense to do MRI. You know, if women find something, you know, when they're washing themselves, or their, doctors notice something, sure, but that would be an extremely rare phenomena. And even for women who've had breast cancer and then have risk-reducing mastectomies, the chance of chest wall recurrence today is really, really low. Our systemic therapies, our radiation are extremely good at preventing local recurrences. And most local recurrences turn out to be quite superficial and are not hidden by the reconstruction. So that's usually not a problem. Most of these women are followed up by an oncologist or by their family doctor during the time when they're at highest risk of recurrence anyways. So really just, awareness on the part of the woman, periodic examination by a healthcare professional is all they need. They don't need any imaging, and in particular, they don't need MRI.
Great, thank you.
Okay, so I'm just navigating through some of these questions, and there was actually a little bit of discussion about the breastfeeding. So I think you already alluded to the fact that you do imaging now on women who are breastfeeding. But someone brought up the fact that she was diagnosed with an early onset cancer, and this happened while she was breastfeeding her child. And maybe if you could give some insight into pregnancy-associated breast cancers and what we see in mutation carriers.
So in all women, there's a slightly higher risk of breast cancer during pregnancy and probably in the two years or so after pregnancy. After that, pregnancy actually protects women from breast cancer. So women need to be a bit more aware. Also, the cancers that are found during pregnancy, they're a little harder to find during pregnancy or breastfeeding. And that's because the breasts are engorged, lumpy, and so forth. So again, it's difficult, and women and their physicians need to be aware and, investigate something that doesn't seem quite right. There is no special difference, I think, between BRCA mutation carriers and non-carriers in terms of the types of cancer they get. It's just overall, the risk would be higher in mutation carriers. We don't do screening during pregnancy, but obviously if a lump showed up, we would do something diagnostic. The first thing we would turn to would be ultrasound, which is not harmful to the baby in any way. Mammography can be done if necessary safely. So investigating a lump is not a problem. And once a woman is breastfeeding, if she decides to breastfeed for more than 6 months, we'll do screening. But obviously, if she gets a lump anywhere along the way that we're worried about, we investigate it. And what's tragic is when growing lumps are dismissed as, oh, well, must be just, a milk duct or a block tube or whatever. No, women have to be really vigilant, as do their physicians. But there's no reason why a mutation carrier shouldn't breastfeed just like anybody else.
Okay, thank you.
Next question, Dr. Warner, is about men with the BRCA1 and BRCA2 mutation. And are there any recommendations for breast screening for men? And what would that look like?
So, I think every sort of institution has their own guidelines. BRCA1 mutations don't cause a whole lot of breast cancers in men. And I don't think, the risk would be nearly high enough to justify any type of formal screening other than, awareness, like what we call breast awareness, which is what we recommend for all people anyways. Certainly for all women and certainly for any man who's a mutation carrier. BRCA2, a little bit higher, but again, because most of these cancers are easy to feel, I don't think it's generally considered necessary to screen men with imaging. Probably, a self-examination periodically would be reasonable, or certainly anytime a man with a BRCA2 mutation goes for a general health physical exam, their breast should be examined as well.
And maybe this is an opportunity to plug the clinic at Sunnybrook that does follow men with BRCA mutations. I think Dr. Vesperini is still doing that. So that's something that we could let men know about as well.
Yeah, that's a great idea. And what's a bigger risk to them is their prostates.
Yeah.
And I think Dr. Vesperini is on our panel to speak in the upcoming months.
Yeah, so look out for that talk coming up in the next few months. But again, he can also talk to us a little bit about the recommendations for men with BRCA1 or 2 mutations. Okay.
Okay, so a lot of questions regarding just genetic testing in general. So depending on where you live, you can access genetics clinics. We also have the Screen Project at Women's College Hospital, where you can also find some information. But any genetics clinic in your area should be able to help you navigate the system. Kelly, I don't know if you have some more insight on that, but there's a lot of questions on how to get testing.
And testing for your daughters. And often that's one of, a concern of many women who have daughters who may be approaching the age where genetic testing is available, whether or not it's appropriate for that daughter at that time. Again, for those kind of questions, it may be worth getting back in touch with your genetic counselor that you originally saw and having some of those discussions, and potentially your children could visit the genetic counselor and make an informed decision about whether or not genetic testing is appropriate at this time for them. There's a lot of things to be thinking about. Even though legally they're able to get genetic testing at the age of 18, it may not be the best time for every young adolescent.
And there's a lot of women here that are continuing to thank you for being in your study, Dr. Warner, and that you've saved their lives. So thank you.
Yeah.
Well, I thank the women. Without them, we wouldn't have any of this data. So they've helped save other women's lives, as you guys so nicely pointed out.
Yeah, you're right. Okay, there's a question here about if you find cancers with screening, if you find some of these early stage breast cancers that are treatable, what would the typical treatment look like for these women? Would they all have to undergo chemotherapy? So can you just walk us through what might happen with those women, even when they're diagnosed with, say, a stage 1 breast cancer, no positive lymph nodes, but they're 35 or 40 years old?
So that's a really great question. So I think you have to divide them into the ER positive and the ER negative. So ER positive are tumors with hormone receptors that are sensitive to hormone treatment. And those cancers generally, if they're under a centimeter, will not require chemotherapy. They can be treated usually with lumpectomy, so a small surgical procedure, usually gives a great cosmetic result to the breast. Radiation, again, is done if there's only lumpectomy and not mastectomy. And those women will probably just need hormone therapy for 5 years, which is a pill once a day, doesn't interfere with their life or in any way. Once the tumor is over a centimeter, we will usually send that patient for some sort of molecular test to see whether that tumor is more biologically aggressive and also more sensitive to chemotherapy. So some of those patients may need chemotherapy and many will not. With the ER negative tumors, it's a little bit different. We're more likely to give chemotherapy. Anything over a centimeter, we would. Anything under a centimeter, it's really kind of an individual case based on the woman's age, other biologic features of the tumor, personal choice and so forth. The surgery would be the same and the radiation would be the same. But, these women, it's compatible with not a terribly difficult time. Many of these women don't even have to stop working if they don't get chemo and, just get on with their lives and have no long-term sequelae after.
And well, maybe you can just add when we're comparing BRCA1 to BRCA2, when you were talking about estrogen receptor status. So can you tell us a little bit more about BRCA1 versus BRCA2? Are they more likely to have one versus the other?
So great point. So BRCA1, about 80% of those cancers are ER negative, about 20% are ER positive, and it's flipped for BRCA2. So about 80% of those tumors are ER positive and the rest ER negative.
Okay, thank you for clarifying that for us.
Okay, so I think we're reaching the end of our time, and I know our session seems to pop us off at once. So I wanted to thank Dr. Warner for her time, for a very informative presentation. Thank you so much.
My pleasure.
A lot of the questions that were asked, as Dr. Metcalf mentioned, would be better answered in a genetic setting. So please feel free to reach out to the genetic center in your area to help answer these more personal questions. And I just wanted to continue and mention that our next presentation, is this showing right now? Our next seminar is on Friday, April the 16th. And Dr. Karen Glass will be discussing fertility options for mutation carriers with or without a personal history of cancer. And all this information is on the Eventbrite website at the bottom of the slide and also on the Women's College Hospital website. And a lot of you were also asking if we're posting these seminars. All these seminars will be posted on our website also, so you'll be able to access them and share them widely at any time. It might not happen for a week or two, but we will have them posted. And so I want to thank everyone for their time. Dr. Warner, Dr. Kelly Metcalf, and I thank you and hope you continue to join our virtual hereditary cancer series.
Thank you for inviting me. And good
Thank
luck with
you
the
to
series.
everybody.
It's great.
Have a good day.